Welcome back to the deep dive. Now, if you're a GP trainee getting ready for, well, exams like the Applied Knowledge Test, you'll know oncology essentials are really high-stakes stuff.
Absolutely,
It's
yeah.
not just knowing the basics. You need the exact numbers, the precise cutoffs, and those rare but really critical associations.
That's spot on. We've basically gone through the core reading materials to, create a really focused deep dive for you today.
Right?
Our mission really is to cut through all that noise and just deliver the critical facts. We're focusing on two main areas: population health, so screening, epidemiology, and then shifting into advanced disease, specifically metastasis patterns and those tricky paraneoplastic syndromes.
Yeah, we're aiming for depth today, making sure we get not just what the rule is, but why it's there. That's pretty crucial for actually applying this knowledge, isn't it?
Exactly. We're trying to translate these high-volume facts into, well, practical, recallable concepts.
Okay, good. Let's unpack this then. Let's jump straight into the kind of numerical precision you need for the UK population screening guidelines. This is really the bedrock in primary care oncology. And getting the ages and frequencies wrong, that's just not an option for the exam.
Right. And these guidelines, they're based on massive amounts of data, epidemiological data. It's all about finding that optimal balance between catching disease early and avoiding overscreening and all the harms that come with that.
Makes sense.
That's why the ages and the intervals are so strictly defined.
Okay, let's start with breast cancer screening. That uses mammography. What's the active, automatically invited range and the standard frequency we need to know?
Okay, so the standard range for automatic invites based on the NHS program, that's from 50 years right up to 70 years of age.
50 to 70.
Yep. And the critical frequency is every 3 years. That 3-year gap, it's basically a balance between, catching interval cancers and the logistics, cost, and exposure risk of doing it more often.
Right, that 50 to 70 window, that's often the main fact people remember. But the AKT loves the nuances, doesn't it? Especially about what happens after. So patient turns 71, do things just stop?
No, absolutely not. And that's a really common point of confusion, actually.
Mm-hmm.
So while the automatic invitations stop at 70, the patient still has the option to carry on with screening. The key fact here is that the patient can self-refer after the age of 70 years. So our role in primary care, especially as GPs, it shifts a bit. We're not inviting them anymore, but we should be actively encouraging them to continue if they want to, making sure they understand that the risk still goes up with age.
Got it. So active encouragement, not automatic invite. Okay, moving on to bowel cancer screening. Different technology here, completely different schedule too, I think.
Yeah.
Reflects the natural history of polyps and cancer.
Correct, yeah. Colorectal screening, it currently uses the FIT test, the fecal immunochemical test, much more sensitive than the old EpoBT test for picking up hidden blood.
Right.
And the age range for this one is actually a bit wider than breast screening. It runs from 50 years up to 74 years of age.
50 to 74. And the frequency is tighter, isn't it? Shorter intervals here.
Yes, exactly. The frequency is every 2 years.
2 years.
That shorter interval, it reflects the worry about how fast some premalignant adenomas can progress to, invasive cancer. It can happen quicker sometimes than breast changes picked up by mammography.
Okay, that makes sense. And like breast screening, there's that option for patients after they leave the automatic invite window.
Precisely. After age 74, the automatic invites stop, but patients can self-refer after the age of 75 years. So the door stays open for those who want to keep up that biennial check.
Good to know. Okay, we've seen the ages shift a bit between breast and bowel, but cervical screening. That's where the precision really matters, isn't it? With the frequency split based on age. What's the absolute high-stakes fact we need here about that age and frequency split?
Yeah, this is definitely the most complex schedule. It reflects different risk factors, mainly HPV exposure and progression rates across a woman's life. And you really have to memorize the split.
Okay.
So first, for women aged 24 years up to 49 years, screening is every 3 years.
24 to 49, 3-yearly.
Then second, for women aged 50 years up to 64 years, the interval gets longer. It goes to every 5 years.
Right. So younger women, more intensive 3-year checks, maybe reflecting higher rates of high-grade changes found then, and older women towards the end of the program every 5 years.
That's the key idea, yeah. If you look at the risk profile, the rate of new high-grade abnormalities like CIN2 or 3, it statistically drops after age 50.
Okay.
So that justifies easing off the intensity a bit without compromising safety.
And what about the crucial negative detail?
Yeah.
This is the one that's totally different from the other two programs, making it super testable for the AKT.
This is the absolute #1 differentiator you have to remember. There is no self-referral after the age of 64 years.
Right. No self-referral at all.
None. Unlike breast and bowel screening, the cervical screening program just finishes. It concludes at 64, assuming previous results were normal, obviously. There's no standard way to continue unless there's specific clinical reasons.
So if a patient is 65 and asks,
The professional advice has to be that the program has ended for them. This hard stop is just a vital distinction to commit to memory.
yeah, it's a clean break. And for anyone prepping for the AKT, that contrast, self-referral for breast and bowel, no self-referral for cervical, that's a critical piece of information for your notes.
Absolutely. Aligning that surveillance intensity with the known risks and those sharp age cutoffs, that's really the core of primary care prevention in oncology.
Okay, now let's pivot from prevention to the current reality of disease burden, epidemiology. And here, we really need to grasp the difference between high incidence, what's diagnosed a lot, and high lethality, what causes the most deaths. The goal here is basically memorizing two distinct lists: the most common cancers diagnosed and the leading causes of cancer death.
Yeah. Confusing incidence with mortality is such a common exam trap.
Right.
If you mix these up, you'll definitely lose marks. So we need a systematic way to anchor these facts.
Okay, let's start with prevalence then. What do we diagnose most often? We need to break it down by gender first. So for males, there's that simple mnemonic PLC.
PLC, yeah. That stands for #1, prostate cancer, #2, lung cancer, and #3, colorectal cancer. Prostate cancer, well, it benefits a lot from screening like PSA testing and just general awareness, so that puts it right at the top for male diagnoses.
Okay, PLC for men. And for females, the main one changes, right? The acronym becomes BLC.
BLC, that's right. #1, breast cancer. #2, lung cancer. And #3, colorectal cancer. Breast cancer is just overwhelmingly the most common cancer diagnosed in women, largely due to, high screening uptake and also increasing age-related incidence.
Right. So if we put that all together for the whole UK population, both genders combined, the ranking settles back to BLC.
Yes. Even though prostate is #1 for men, breast cancer is still the most common overall diagnosis because there's just such a high volume in the female population.
Okay.
Then it's followed by lung cancer and then colorectal cancer. So the key takeaway is breast cancer leads in prevalence overall.
Got it. That's the volume perspective. But before we hit mortality, there's one crucial outlier fact. We need to lock down pediatric epidemiology.
Ah, yes, a vital point, totally different from adult medicine. The most common cancer we see in children, by quite a long way, is leukemia.
Leukemia.
That's a non-negotiable fact for anyone covering child health. Definitely remember that one.
Okay, leukemia in kids. Now, let's pivot hard to lethality. When we look at which cancers actually cause the most deaths, the list changes quite dramatically, and the acronym shifts to LCB.
LCB, yes. #1, lung cancer. #2, colorectal cancer. And #3, breast cancer.
Okay, pause here. This is where we need to really draw that sharp contrast.
Wow.
Why does lung cancer jump from #2 in prevalence overall to #1 in mortality? And why does breast cancer drop down the list, even though it's diagnosed so often?
Right. This is where you apply the knowledge. Lung cancer's lethality, well, it's driven by a few things. Often presents late, vague symptoms that mimic common chest issues.
Yeah.
And it's often biologically aggressive, frequently diagnosed at an advanced stage where surgery, a cure, is just not on the table anymore.
So we diagnose breast cancer most often, but the death rate is significantly lower, largely because screening, like mammography and really effective treatments afterwards, have massively improved the outlook over the last few decades.
Exactly. The high incidence of breast cancer, the prevalence leader, coupled with those effective treatments means it ranks lower on the mortality list. The absolute key takeaway is lung cancer is the undisputed leading cause of cancer death. That distinction is paramount.
Right, moving on now. From population data to advanced disease and the common patterns of cancer metastasis. This is about translating a patient's symptoms, maybe in secondary care like new focal neurology or bad back pain or sudden breathlessness, into a likely primary cancer diagnosis.
Yeah, metastasis isn't just random. It tends to follow predictable routes governed by things like blood flow and specific molecular attractions, you could say.
Yeah.
Understanding these patterns helps us narrow down the possibilities really quickly when a patient shows up with a lesion and we don't know where it started.
Okay, let's look at the central nervous system first. Which primary cancers most commonly manage to cross the blood-brain barrier and set up shop in the brain?
The two big ones here, the dominant primary culprits, are lung cancer and breast cancer. Brain mets can present quite dramatically new seizures, confusion, focal weakness, persistent headache.
Right.
And given how common both lung and breast cancer are, they absolutely have to be top of your differential if a patient with a known history or even just new systemic symptoms suddenly develops neurological problems.
Okay, lung and breast to brain. What about the lung itself? It's a common site for mets from other primaries, right?
hmm
Often through the venous return to the heart.
Exactly. The associations here are mainly breast cancer and colon cancer.
Breast and colon to lung.
Yeah, it kind of makes sense physiologically. Venous blood from the breast and the abdomen eventually flows back through the pulmonary circulation. So if a patient presents with, say, unexplained coughing up blood or recurrent pleural effusions, you definitely think about working them up for these primaries.
Okay. Finally, bone metastases. Often a really painful presentation, isn't it? Deep, relentless bone pain, or sometimes, unfortunately, a pathological fracture.
Yeah, bone is a very rich, very vascular environment that certain cancers seem to specifically target. The two dominant primary cancers that spread to bone are prostate cancer and, again, breast cancer.
Breast cancer again. This is where we need to sort of pull the list together in our heads. Breast cancer showing up in all three lists: brain, lung, and bone. He seems like a metastatic generalist.
That's a great way to put it, yeah. A generalist capacity. It's crucial. If you see a female patient, unknown primary, but presenting with symptoms across multiple systems, maybe back pain and new neurological issues, breast cancer should be very high on your suspicion list. Needs specific checks.
But the really high-yield facts for exams are often those unique pairings, right?
Excellent. You anchor these specific links. Prostate cancer has this really strong, almost iconic affinity for bone, often causes osteoblastic bone-forming lesions.
Prostate to bone.
And while colon cancer classically spreads to the liver, our sources specifically point out its strong potential to metastasize to the lung.
Colon to lung.
So use those unique pairs, prostate to bone, colon to lung, to keep your differential clear, especially differentiating from that pervasive breast cancer link, which goes everywhere.
All right, let's move to probably the most clinically complex and maybe the trickiest area for the AKT. Paraneoplastic syndromes. These are those really high-yield spot diagnoses where the symptoms are systemic, miles away from the actual tumor, caused by substances the tumor itself is pumping out. Requires understanding the physiology, I guess.
Definitely. These syndromes happen because the tumor acts like an ectopic rogue endocrine gland, or maybe it provokes an immune response. Knowing the mechanism really helps anchor the specific cancer association.
Okay, let's start with the endocrine and metabolic ones, the hormonal mimics. Cushing syndrome first. That's excessive cortisol activity. How does a cancer cause that, and which ones are the main offenders?
Right. Cushing's in this context is usually caused by the ectopic secretion of ACTH, adrenocorticotropic hormone.
Okay.
When a tumor makes it, it just bypasses the body's normal feedback control. The main cancers associated are small cell lung cancer, SCLC, pancreatic cancer, and renal cancer. SCLC is probably the most famous one, causing really rapid, quite severe Cushing's features.
Small cell lung cancer for Cushing's. Okay, sticking with lung cancers, let's move to SIADH syndrome of inappropriate antidiuretic hormone secretion. Causes low sodium hyponatremia because of water retention.
Exactly. SIADH is specifically associated with SCC of the lungs squamous cell carcinoma.
Ah, squamous cell this time.
Yes. The tumor secretes ADH, or vasopressin, ectopically. Too much ADH makes the body hold on to water, diluting the sodium in the blood dilutional hyponatremia. And note that crucial difference in histology. Cushing's was small cell, SIADH is squamous cell. Keeping those lung subtypes straight is vital for these syndromes.
Got it. SCLC Cushing's, ACTH, SECC, SIADH, ADH. Next, hypercalcemia. High calcium. Now, that could be a general sign in advanced cancer because of bone mets, but there's a specific association driven by a humoral mechanism, not just bone breakdown.
Yes, while high calcium is a general indicator, the specific humorally mediated link we need to remember is again with SCC of the lung.
SCC again. Okay.
This happens because the squamous cell carcinoma secretes something called PTHRP, parathyroid hormone-related peptide. Yeah, it mimics what real PTH does, basically telling the kidneys and bones to retain and release more calcium. Leads to significant hypercalcemia, even without massive bone mets sometimes.
Wow. Okay. So SCC of the lung is dominating this hormonal list, linked to both SIADH and PTHRP-driven hypercalcemia. Pretty disruptive subtype.
Definitely. It really shows the incredible systemic reach these particular tumor cell lines can have.
Right. Switching gears to an unusual metabolic thing. Hypoglycemia, low blood sugar.
Hypoglycemia, in a perineoplastic context, the association is with ovarian cancer.
Ovarian, okay.
Yeah, it can happen if the tumor produces insulin-like growth factors, IGFs, or maybe other substances that push blood glucose down. It's less common, but it's a really high-yield fact if you see sudden onset low blood sugar in a patient who might have a pelvic mass.
Good one to remember. And finally, in this section, polycythemia, too many red blood cells.
Polycythemia is linked to the tumor secreting excessive erythropoietin, or EPO. The major associations here are renal cell carcinoma and also cerebellar hemangioma.
Renal cell carcinoma makes sense, physiologically.
It does, yeah, because the kidney is where EPO is normally made. The tumor basically hijacks that system, leading to a high red cell count. Hashtag 4.2. Neurological and local syndromes.
Okay, moving away from hormones now, more to the neuromuscular system. Let's talk Lambert-Eaton syndrome. Need to distinguish this from things like myasthenia gravis, right?
Yes, absolutely. Lambert-Eaton involves muscle weakness, but the key feature is that it characteristically improves with repeated effort.
Improves with use, unlike myasthenia.
Exactly. Myasthenia gravis fatigues easily. Lambert-Eaton is a presynaptic problem. The tumor triggers an autoimmune response, making antibodies against the calcium channels right before the neuromuscular junction. It's strongly associated with SCC of the lung. That clinical clue weakness improving with use is absolutely essential.
Yeah, that improvement with use, that's the classic vignette clue the AKT might use.
No.
Okay, next, Horner syndrome, the classic triad. Ptosis, droopy eyelid, meiosis, small pupil, and anhidrosis, lack of sweating on one side of the face.
Horner syndrome, when it's perineoplastic or caused by local invasion, is associated with a specific type of lung trigger, the Pancoast tumor.
Pancoast tumor, right at the top of the lung.
Yep, located right at the apex.
Mhm.
It causes symptoms by actually invading the sympathetic chain nearby. This is most often linked to squamous cell cancer of the lungs, Pancoast tumor. But our sources also mention a possible non-local perineoplastic link with breast cancer too, though the Pancoast invasion is the more direct and common cause.
Okay, so a clear distinction. Local invasion by a Pancoast tumor versus maybe a rarer systemic effect from breast cancer. We also have just general pain in hands and feet listed, or neuropathy.
Yeah, peripheral neuropathy, pain, numbness, tingling in the extremities that's associated with adenocarcinoma. It can be a tricky diagnosis to pin down specifically to the cancer, but knowing that link to the adenocarcinoma subtype is valuable. Hashtag par 4.3. Other syndromes, the unique associations.
Okay, let's wrap up this section with two quite unique clinical pictures, starting with carcinoid syndrome. Has a classic presentation triad, doesn't it?
It does. Carcinoid syndrome is caused by vasoactive substances, things like serotonin and kinins, secreted by neuroendocrine tumors. The key symptoms you need to know are diarrhea, flushing, often face or upper body, and low blood pressure, hypotension.
Diarrhea, flushing, low BP.
Yeah, and normally these substances get cleared out by the liver, so the syndrome usually only becomes clinically obvious when the primary tumor bypasses the liver somehow, or more commonly, when the liver itself is full of metastases.
Right, the liver can't clear it anymore. And what cancers are typically responsible for this systemic overflow?
The primary cancers listed are bronchial cancer, which is a common place for carcinoid tumors to start liver metastases, which usually implies the primary was somewhere in the GI tract, but it's now symptomatic because the liver mates prevent clearance, and also hepatocellular carcinoma, which sometimes can show neuroendocrine features itself.
Okay, and finally, one of the most sort of esoteric but still highly testable facts. Stauffer syndrome. What exactly defines this one?
Stauffer syndrome is defined as non-metastatic hepatic dysfunction. Basically, abnormal LFT's liver function tests in the setting of renal cancer. Non-metastatic hepatic dysfunction. Exactly. The liver is abnormal, maybe cholestasis, maybe enlarged, but there's no actual tumor spread to the liver. It's a systemic effect from the renal tumor, possibly cytokine-mediated, is the thinking.
That non-metastatic part is huge. The cancer is affecting a distant organ without actually being there. And this fact lets us circle back and see how prominent renal cancer is in these syndromes overall.
Yeah, if you connect the dots, renal cell carcinoma really is a systemic disruptor, isn't it? We've linked it to Cushing's syndrome, to polycythemia, and now to Stauffer syndrome.
Right.
So if you get a clinical vignette describing a kidney mass along with, say, unexplained high red cell count or weird LFTs, you absolutely have to consider RCC and its perineoplastic potential. That's exactly the kind of cross-system thinking that AKT requires. Hashtag tag outro.
Wow, okay. This has been an incredibly detailed run-through of essential oncology facts. We've covered the whole spectrum, really, from population screening right through to these complex syndromes. We spent a good chunk of time nailing down those specific age cutoffs,
Yeah.
the critical difference between incidence and mortality, and the mechanisms behind those really tricky paraneoplastic links.
Yeah, we really tried to reinforce those crucial differentiators, that hard stop at 64 for cervical screening, the prostate to bone metastasis link, and just the sheer number of syndromes tied specifically to lung cancer subtypes XCLC versus SCC.
Hmm.
Understanding these precise details, the why, the rank order, the specific pairings, that's what really gives you that exam-ready mastery, I think.
Absolutely. So what does this all mean when you look at everything we've covered from the sources? One thing that just keeps jumping out across all the sections, epidemiology, mortality, metastasis, and paraneoplastic syndromes, is the huge systemic impact of lung cancer.
It's true. It really seems to be the most systemically disruptive common cancer. It's number 2 in overall diagnosis, number 1 in cancer deaths.
Yeah.
And its subtypes are linked to, what, 3 distinct major endocrine or neurological syndromes we discussed? SCLC causing Cushing's, and SCC causing SIADH, hypercalcemia, and Lambert-Eaton syndrome.
That's a staggering footprint, isn't it? It really
Yeah.
suggests that lung malignancies, maybe because they're so close to major blood vessels and lymphatics, or maybe the neuroendocrine nature of some subtypes, they just have this uniquely broad ability for secretion and systemic interference compared to other common cancers like breast or prostate,
Right.
which often seem more locally contained initially.
That's a great point, and maybe that's our final thought for you, the listener, to mull over as you continue studying. Why do lung malignancies seem to have such a diverse and broad systemic impact? Why are they essentially masters of this paraneoplastic mischief compared to other high-incidence cancers? It's a fantastic way to link up the pathology and the physiology.
A perfect final thought. Thank you for joining us for this deep dive into oncology essentials. We'll catch you next time.